ICD-10 documentation for emergency room physicians. ICD-10 is coming, and of course everyone is concerned about how it's going to affect everyone. But there's not that many changes that's going to affect the emergency room. For instance, one of the biggest things are greater detail in anatomy and pathophysiology, the severity, complexity, and if there's anything else going on that's complicating the patient's condition or making it better or worse. Really, with ICD-10, what's going to happen with the insurance companies is unpredictable. We know what they're telling everyone that's going to happen, but really until we get the claims out there and we start getting denials or rejections, we won't really know if they're going to want more or less of some of the things that we're putting on the claims. Medicare has said that they will not deny any claims from October 1st, 2015 to October 1st, 2016 that are billed for unspecified codes. Some of the changes that are very noticeable from ICD-9 and ICD-10. ICD-9, we have a maximum of 5 digits. ICD-10, we have a maximum of 7 digits. And just to kind of give you an example of the fracture codes and how they change from ICD-9 to ICD-10, in ICD-9, for a closed fracture of the femur, we have 16 codes to choose from. In ICD-10, for a closed fracture of the femur, we have 1,530 to choose from. Also in ICD-10, we are introduced to 7-digit extenders and placeholders. In the next few slides, I'll go over just some examples of some codes that we normally see in the emergency department and compare the ICD-9 code to the ICD-10 code. So the first one, acute cystitis. Before, if we had that diagnosis, it was just simply 595.0. Now we need to know if it is acute cystitis with or without hematuria. ICD-9, sprain and strain were the same in the diagnosis, but now in ICD-10, we need to know the difference between sprain and strain. Pressure ulcers with ICD-10, we need to know the patient's BMI, we need to know the laterality, the location, the stage of the ulcer if known, and if it's healed or not healing, and the BMI can be taken from the nurse's notes. The physician does not have to get that information themselves. HIV, the rules are the same, but we do have some codes now for counseling, and then we just need to know if the patient is asymptomatic, if they've been exposed to HIV, if they're coming in just for a simple blood test, and any type of counseling that you provide to that patient regarding HIV. Sepsis remains the same, with the exception of you no longer can simply state urosepsis. In ICD-9, if we looked up urosepsis, it referred us to a UTI. But in ICD-10, urosepsis is not even in the book. So if we were to receive charts with urosepsis, we would have to defer those back to the provider for more information. And with sepsis, just keep in mind, if we know the underlying infection or any type of organ failure or dysfunction, that needs to be noted in the chart. Diabetes is no longer stated as controlled or uncontrolled. Other than that, it's the same with a few exceptions. We just need to know if there's any complications or anything going on with the diabetes. and any underlying conditions. If hyperglycemia or hypoglycemia is noted, we need to know if it's with or without coma. And retinopathy, we need to know more detail regarding macular edema and so forth. Substance abuse, use, and dependence. As you can see from this slide, everything is going to code out to dependence with the exception of just use and abuse. The nervous system, the documentation should state if the affected side is the dominant or non-dominant side. Migraines, we just need to know the type of migraine, if it's with or without aura, intractable, not intractable, just as much information as you can provide. Poisonings, accidental, intentional, assault, undetermined, underdosing, the adverse effect. With poisonings, with ICD-10, there are a lot of combination codes used in ICD-10, whereas in ICD-9, we would have to use 2, maybe 3 different codes. So as you can see here, some examples of the poisoning codes. If we had an unspecified drug in ICD-9, we would use 977.9. In ICD-10, it gets more specific, and as you can see, the external cause codes that we would use in ICD-9 are now included in the code with ICD-10, such as intentional, unintentional poisoning, and so forth. In ICD-10, ear has its own chapter. And anytime with ear infections, basically we just need to know acute, chronic, acute on chronic, perforated, and if the patient is exposed to smoke or do they smoke. Hypertension is no longer stated as controlled or uncontrolled. We have a lot of combination codes with hypertension in ICD-10. And if there's any relationship between other diseases, this must be stated or implied, such as hypertension with heart failure. And again, the same as with ears, if it's heart failure, they want to know if the patient is exposed to smoke or if they smoke themselves. Hypertension with heart disease and kidney disease. Hypertension with heart failure and chronic kidney disease are related. We must have the type of heart failure and the stage of the chronic kidney disease. If you have heart failure, you need to code first whether the heart failure is due to underlying conditions such as heart failure due to hypertension with chronic kidney disease, rheumatic fever, any complications or anything that the heart failure is due to, that must be coded first. So we would need to make sure that that information was located in the patient's chart. Congestive heart failure is no longer a code by itself in ICD-10. Now heart failure is broken down into left ventricular failure, systolic heart failure, diastolic combination, and then just heart failure unspecified. And as you can see, the systolic and the diastolic, it needs to be specified if it is acute, chronic, acute on chronic, or unspecified. This kind of shows the difference. In ICD-9, we had congestive heart failure unspecified. If we were to see that on a chart with ICD-10, we would have to code that as heart failure unspecified. Respiratory failure in ICD-10 is more complex. It's not simply respiratory failure. Again, we need to know if it's acute or chronic. With hypoxia, anything else that's going on with respiratory failure needs to be noted because there are several new combination codes that we can use. Pneumonia, if we know the specific type, probably in the ED we will pneumonia unspecified, depending on if we already know what specific type of pneumonia the patient has. Injuries are no longer noted as complicated. We need to know if it's with or without foreign body. Again, we need to know sprain versus strain. ICD-10 classifies those as sprain is classified as a damage to a ligament. Strain is classified as damage to a tendon. Lacerations, again, the complicated has been omitted. It is no longer in ICD-10. We basically need the documentation to let us know if the laceration is infected or if there is a foreign body. ICD-10 now breaks down the codes regarding if it's a puncture wound, if it's a bite, or a laceration, or an open wound. So it goes into more detail, and we have a variety of new codes that we can use when it comes to injuries. Debridement, anytime that this is in your note, just keep in mind that we need to know the type of instrument that was used, because that helps us with determining if it's excisional or non-excisional. So simply documenting excisional debridement is not enough. We need to know, again, the type of instrument that was used, the extent and depth of the procedure, if there was cutting away of tissue, just a detailed procedure note. Fractures with ICD-10, they are very specific compared to how they were in ICD-9. We need to know the type of fracture. First of all, we would need to know if it's closed or open. And then if you can go more in detail as the type of fracture, that also needs to be documented in the patient's medical record. We have 7th digit extenders for injury codes, and they are initial, subsequent, and late effect. The initial is if the patient is still receiving active treatment for the chief complaint or the reason that they're coming into the emergency department. So a good example would be laceration was repaired by ED physician number 1. 3 days later, the patient comes back in because they're concerned that the laceration or the wound is infected. Both encounters are considered initial treatment because the patient is still in the active treatment period. So if the patient comes in to have their sutures removed, that's after active treatment. So in that situation, the chart would be coded as subsequent care. These are some of the 7th digit extenders that are used for fractures. These are the ones that we're not going to use most of these in the emergency department because, as you can see, they get really detailed as far as the type of fracture, type 1, type 2. With the emergency department, as long as we can explain if it's closed or open, and if you could be more specific as to the type of fracture, that's very helpful. This is an example of a chart. As you can see, it's noted as just patella fracture visualized on the x-ray. And this is a very brief note. But the next note is going to come up. This, you can see that the physician documented his diagnosis as ankle fracture. But at the top in his documentation, he has noted that there's a closed, grade C, non-displaced fracture of the fibula. So as long as that is in your medical record, the coders can pull that information and use that to code a more specific fracture diagnosis. So the fact that the physician only has ankle fracture noted in his diagnosis section of the chart, that's okay. As long as more detailed information is somewhere in the chart that can be pulled. So the physician doesn't need to worry about having to document things twice just for coding. External cause codes are very different compared to ICD-9 because they get a lot more detailed. As you can see, if a patient is in a motor vehicle accident, they want to know what type of vehicle. Was it a car, an SUV, a truck, a van, and then what type of car did you hit? So they want to be the specific type of motor vehicle or the type of vehicle that you were in. And for home accidents, they want to know where. Where were you in the home? What room? Or where were you outside? And then what type of home were you in when you had the accident? The other thing to remember when you're doing your documentation is make sure that the reason for admission, if the patients are going to be admitted, is very clear. Especially this helps if the patient is outpatient and they're going to inpatient. Um, it also helps with medical necessity. There's readmissions that it can prevent, and also claim denials. So overall, the new concepts for ICD-10, we should avoid using unspecified codes unless you have no other choice. For instance, if a patient comes in and they have a laceration or a sprain of the knee, there are codes that state unspecified knee. So those are the type of unspecified codes that we should avoid using because we should be able to document if it's the left or the right. Initial and subsequent encounters are new for ICD-10, and these are only for injuries, fractures, and related external cause codes. But to break everything down into percentages, it's estimated that about 50% of the required documentation for ICD-10 is already required in ICD-9. 50% is laterality, and of that 50%, 10% is all that's new. And most of the documentation changes are within the musculoskeletal section, which is about 36% of that change involves documentation of laterality. So if you look at it that way, in those numbers, it's not going to be a huge change for the emergency room physicians. So I hope that this provided you with information that you need for ICD-10, and thank you for your time.